So, to definitively prove a patient has suffered a post-operative myocardial infarction right after cardiac surgery, their blood markers have to exceed 10 times the normal lethal limit,
Yeah, 10 times.
which is just, I mean, that singular metric from our source material today really captures just how incredibly violent the act of saving a human heart can actually be.
It really is. You're not just, setting a broken bone or repairing a clean laceration.
Right. You are intentionally stopping, dismantling, and then restarting this high-stakes biological engine because the heart is, it's a mechanical pump, it's a pressurized plumbing network, and a highly sensitive electrical grid all wrapped into one single organ.
Exactly.
And today, for you, our listener, we are going on a custom-tailored deep dive into how modern medicine evaluates, visualizes, and repairs this machine. And we're pulling all of this directly from excerpts of a foundational medical text, Kaplan's Essentials of Cardiac Anesthesia for Cardiac Surgery.
Which is, it's a heavy text because operating on that biological engine requires just an immense amount of predictive data before a scalpel ever even touches the skin.
Right?
And the surgical trauma inherently skews all the standard diagnostic markers. Like if you arrive at an emergency room with chest pain, a microscopic bump in your troponin levels.
That's the protein that leaks out of damaged heart cells, right?
Yeah, exactly.
Mm.
A tiny bump in troponin is an immediate red flag for an MI, a heart attack.
Wow.
But after a coronary artery bypass graft, troponin is universally elevated purely from the physical trauma of the procedure itself. The surgeon literally has to cut into the myocardium.
So that's why the diagnostic threshold requires troponin to be more than 10 times the 99th percentile of the upper reference limit.
Right. Diagnosing a failure requires filtering out the massive baseline noise of the surgical trauma itself.
Okay, let's unpack this, because before any medical team even attempts a procedure that traumatic, they really need to know if the biological engine can actually survive the repair.
Right. They do. You can't just put a patient on a bypass machine without a really solid mathematical model of their odds.
And looking at the history here in the text, the evolution of predicting survival is essentially the story of data science catching up to biology. Like, back in 1983, a researcher named Payment developed an 8-factor score.
Yeah, the payment score.
Where you were basically just categorized as normal, increased, or high risk, which seems like a super blunt instrument.
It was very blunt. Payment's model laid the groundwork, sure, but the medical field quickly realized that human physiology just cannot be reduced to a simple 3-tier system.
Right.
So then the Parsonet Index followed, and that assigned distinct mathematical weights to 14 different clinical variables.
And that eventually evolved into the massive registries we use today, right? Like the Society of Thoracic Surgeons or STS database in North America.
Yeah, the STS and the EuroSCORE II over in Europe. But, analyzing millions of data points across these disparate models reveals this really stubborn clinical reality. Well, the variables that consistently spike surgical mortality remain completely universal.
Like advanced age or impaired left ventricular function, and obviously the surgical urgency of the procedure, those seem like obvious red flags.
They are. But things like female sex, body habitus, and whether it's a reoperation, those carry immense mathematical weight for some highly specific physiological reasons.
Yeah, and the physiological reasons behind those data points are really what elevate this beyond just a simple spreadsheet.
Absolutely.
Like the increased risk for female patients, for instance, the text says that's heavily tied to the fact that female coronary arteries historically have a smaller physical caliber.
Right, which makes the actual mechanical grafting much more technically demanding for the surgeon.
And then obesity drastically alters the pharmacokinetics of anesthesia, right? And complicates mechanical ventilation.
Yeah, it changes everything, and a reoperation is it's tough because the surgeon is no longer opening a pristine chest cavity.
They're cutting through old sternal wires.
Yeah, dissecting dense, fibrous pericardial adhesions from the previous surgery just to access the heart.
So is calculating surgical risk basically like an insurance actuary figuring out your premium, but instead of money, the currency is your actual survival?
What's fascinating here is that the modern STS model is vastly more dynamic than an actuary's static life expectancy table. It actually auto-calibrates.
Wait, really? It learns?
Yeah, the model utilizes an observed overexpected, or OE ratio, that gets updated quarterly to provide real-time national benchmarking.
Wow.
So as surgical techniques evolve, or as new bypass machines hit the market and national outcome averages shift, The algorithm actively learns and adjusts. It's basically a living statistical model that gets mathematically smarter every few months.
But I mean, statistical probability doesn't show the surgeon where to actually cut.
No, it doesn't.
Once that risk calculus is deemed acceptable, the medical team needs a high-fidelity map of the individual's specific mechanical failures. They have to actually peer inside the chest.
And the cornerstone of that imaging really remains echocardiography.
Ultrasound.
Exactly. And the primary metric they pull from those ultrasound waves is the ejection fraction. They're analyzing exactly how well that left ventricle is performing as a mechanical pump.
Right. And the clinical demand for accuracy in calculating that ejection fraction is absolute. Like, the software doesn't just estimate the volume, it relies on complex geometry.
Yeah, the standard measurement technique is the biplane modified Simpson method.
Also called the summation of disks in the literature. And here's where it gets really interesting, because reading through the mechanics of the Simpson method, it sounds like the ultrasound software is literally slicing the digital image of the beating heart like a loaf of bread.
That's a great way to put it.
Like, it divides the two-dimensional image of the ventricular chamber into a series of stacked parallel disks.
Save Zach.
And it calculates the geometric volume of every single microscopic slice, sums them all together to capture the total chamber volume at maximum expansion, and then it recalculates the entire stack at maximum contraction.
And the software executes that calculus continuously, in real time, on a moving target.
Which is mind-blowing.
It is. But ultrasound relies on acoustic windows, which can be obstructed by bone or lung tissue.
So what happens then?
Well, when the anatomical mapping requires absolute spatial perfection, the field shifts to cardiac CT. Modern 256 or 320 slice CT systems possess the temporal resolution to capture a high-definition, three-dimensional rendering of the entire cardiac structure.
And the coronary tree, right?
Yeah, all in the span of a single heartbeat. They literally freeze time.
But CT primarily visualizes anatomy, right?
If the clinical question is about tissue viability, like distinguishing between dead fibrotic scar tissue and living myocardium, cardiac MRI is the gold standard.
Specifically, utilizing a technique called late gadolinium enhancement.
Yes.
And the physics of that gadolinium contrast are just so elegant to me. The dye is injected intravenously, and it behaves differently depending on the microscopic cellular environment.
Right, because healthy, viable heart muscle is densely packed. There's very little room between the cells.
But dead, fibrotic scar tissue has an expanded interstitial space. So the gadolinium dye naturally pools and lingers in those empty microscopic pockets within the dead tissue.
Exactly. So on the MRI scan, the dead scar tissue intensely enhances, lighting up bright white, while the tightly packed, healthy muscle remains dark.
If we connect this to the bigger picture... Wait, actually, that's your line.
Yeah, if we connect this to the bigger picture, that specific ratio of white to dark tissue dictates the entire surgical pathway.
Oh, so...
Well, imagine a patient presenting with profound heart failure and a critically low ejection fraction. Open heart surgery carries a massive mortality risk for this patient.
Right.
The cardiac MRI provides the definitive answer on whether the risk is even justified. The imaging determines if the poorly contracting muscle is actually infarcted and dead, or merely hibernating due to chronic ischemia.
And what's the threshold for that?
The accepted clinical threshold is 50%. If the transmural thickness of that bright white scar is less than 50% of the ventricular wall, the tissue is deemed viable.
Meaning it could wake up.
Exactly. It has the potential to regain function if the surgeon restores the blood flow. That single measurement is the ultimate gatekeeper for surgery.
Okay, so once you have that high-fidelity map and you know the tissue is viable, you face a critical fork in the road regarding how to actually rebuild the vascular network.
The plumbing debate.
Yes, the plumbing debate. Do you fix the blockages from the inside using a percutaneous catheter, or do you perform a sternotomy and rebuild the vessels entirely?
Right.
And the evolution of the cath lab is just wild. Kaplan's details the introduction of balloon angioplasty in 1977, and the failure rates were catastrophic.
Oh, yeah. Nearly 5% of those early procedures resulted in acute vessel closure.
Which means?
It means the balloon would tear the delicate intimal lining of the artery, the vessel would instantly collapse, and the patient would literally be sprinting down the hall to the operating room for crash bypass surgery while actively dying.
That is terrifying. But today, the failure rate for percutaneous coronary intervention, or PCI, has plummeted to less than 1%.
It's a huge shift. The sheer safety profile of modern catheterization is a triumph of biomedical engineering.
But that safety relies heavily on the deployment of stents, right? Those intravascular metal mesh scaffolds left behind to physically prop the artery open.
Yeah, but stents introduce their own unique pathology. The text highlights their Achilles heel, which is restenosis driven by neointimal hyperplasia.
And reading about the pathophysiology of neointimal hyperplasia, it sounds exactly like weeds growing aggressively through a chain-link fence.
That is a perfect analogy.
Because the metal stent is the fence holding back the atherosclerotic plaque, but the vascular wall senses the metal as a foreign injury.
Exactly. And the body's inflammatory healing response causes new aggressive scar tissue, the weed to proliferate right through the metal struts, eventually clogging the interior of the pipe all over again.
So what was the biomedical countermeasure to that?
The drug-eluting stent, or DES. The metal struts are coated in complex polymers that slowly release antiproliferative medications directly into the vascular wall.
So they operate as a localized microscopic weed killer.
Precisely. They actively arrest the cell cycle to prevent that tissue growth. And the transition from first-generation to second-generation drug-eluting stents involved refining those polymers and the stent architecture, which drastically lowered the risk of late stent thrombosis.
Which is the sudden formation as a massive blood clot inside the stent years after implantation.
Right.
So the localized weed killer definitively solves the restenosis problem. You stop the weeds from growing through the fence.
Yeah.
But the biological trade-off seems incredibly precarious. By intentionally stunting the cell growth, you also prevent the healthy endothelial cells from growing over the metal struts.
Right, so the bare metal remains exposed to the flowing bloodstream for months, making it highly thrombogenic.
This raises an important question regarding systemic risk management.
It does. Because the metal remains exposed, the patient is absolutely mandated to maintain dual antiplatelet therapy, usually aspirin combined with a powerful P2Y12 inhibitor like clopidogrel or prasugrel for up to a year. And this creates a terrifying clinical dilemma if the patient suddenly requires emergency non-cardiac surgery.
Like what?
Say they develop acute appendicitis 3 months after receiving a drug-eluting stent. If the anesthesiologist reverses the antiplatelet therapy to prevent the patient from bleeding to death during the appendectomy, the exposed metal in the coronary stent will likely trigger a massive fatal thrombosis.
But if they maintain the antiplatelet therapy to protect the heart,
The patient might hemorrhage on the general surgery table. It is an excruciating high-stakes balancing act.
that exact dilemma perfectly illustrates why the decision between placing a stent via PCI and performing a full coronary artery bypass graft, or CABG, is so consequential.
Absolutely.
And the sources detailed the Syntax trial, which was designed to settle this specific debate. And the data heavily favors the scalpel over the catheter for a specific demographic.
Yeah, if a patient is diabetic or if they have a high Syntax score denoting complex multivessel disease, CBG remains vastly superior.
But the why is what matters for you listening. Diabetic patients don't just have discrete focal blockages. They typically suffer from diffuse systemic atherosclerosis.
Right, the entire length of the vessel is diseased.
So dropping a single stent into a focal blockage doesn't change the fact that the surrounding vascular neighborhood is rotting.
No, it doesn't. A bypass graft completely reroutes the systemic blood flow, jumping over the entire diseased neighborhood entirely. The bypass provides a definitive, durable, anatomical solution for diffuse disease.
Which significantly lowers the patient's need for repeat revascularization procedures in the future.
Exactly. You are trading the intense, immediate trauma of a sternotomy for long-term anatomical stability.
Okay, so we've bypassed the rotting neighborhood or propped open the pipes with stents. The plumbing is perfect, and the mechanical pump is structurally sound.
But none of that matters if the pump's motor loses its rhythm.
Right. The heart possesses its own internal power grid, and as the human body ages, that grid inevitably begins to short circuit.
Yeah, the text ties the prevalence of electrophysiological failures heavily to age. Like atrial fibrillation occurs in less than 1% of the population under 55, but it affects nearly 10% of individuals over 80.
And the clinical strategy for managing those arrhythmias has undergone a paradigm shift, hasn't it?
It has. Historically, cardiologists relied on pharmacological interventions, but antiarrhythmic drugs possess a severe clinical limitation, which is dangerous negative inotropic effects.
Meaning they weaken the pump.
Exactly. While the chemical agent might successfully suppress the chaotic electrical rhythm, it simultaneously depresses the physical contractile strength of the myocardium. You're chemically weakening the very mechanical pump you just spent hours surgically repairing.
That seems counterproductive.
It is. Furthermore, these drugs carry a proarrhythmic potential.
Wait, so the medication designed to terminate an arrhythmia can unpredictably trigger a novel, infinitely more lethal electrical cascade?
Yes. Consequently, the field has aggressively pivoted away from chemistry and toward physical ablation. Electrophysiologists map the endocardial surface to isolate the rogue cells generating the chaotic signals and then purposefully destroy them using radiofrequency thermal energy or cryotherapy.
So what does this all mean? Because I have to push back on the core logic of that approach.
Okay, go for it.
We spent the first half of this deep dive establishing how incredibly dangerous dead scar tissue is to the heart's pumping function. We use advanced MRIs just to calculate if there's too much scar tissue to even attempt surgery.
Right.
So if we are now inserting catheters to physically burn or freeze the myocardium to create permanent scar tissue, aren't we intentionally inflicting the exact type of structural damage we just worked so hard to mitigate?
It's a great question. The concept of intentionally damaging the myocardium seems entirely paradoxical until you examine the specific electrophysiology of an arrhythmia.
Okay, explain.
The vast majority of dangerous tachycardias are sustained by a reentrant pathway. Basically, a rogue electrical signal gets trapped in a continuous, self-perpetuating anatomical loop, overriding the heart's natural pacemaker.
Right.
By burning a highly specific microscopic line of tissue across that loop, the electrophysiologist creates an intentional firebreak. The resulting scar tissue is electrically inert, meaning it cannot conduct a current.
Ah, so the insulating wall physically severs the reentrant loop.
Exactly. It forces the electrical signal to resume its natural linear pathway originating at the SA node, the heart's natural spark plug, and traveling down to the AV node, which distributes the current to the ventricles.
So it is a microscopic, highly calculated sacrifice of tissue to prevent a total systemic collapse.
Yes. Localized destruction to enforce systemic order.
Wow. But that electrical grid gets even more complicated when a patient comes equipped with their own built-in failsafe.
You mean ICDs?
Yeah, I am looking at the anesthesia protocols for patients implanted with cardioverter defibrillators. If that patient requires surgery, the operating room itself becomes an electrical hazard.
It really does. Surgeons rely on electrosurgical units, or ESEs, utilizing high-frequency alternating current to cut through tissue and cauterize bleeding vessels.
And that monopolar energy radiating through the patient's body creates massive electrical interference.
Yeah, right. And the ICD's primary function is to continuously monitor the cardiac grid for chaotic, high-rate electrical activity, which it interprets as ventricular fibrillation, imminent death.
And the high-frequency noise from a surgeon's electrocautery tool mimics that exact electrical signature.
Precisely. If the ICD misinterprets the surgical cautery as a lethal arrhythmia, it will instantly deliver a massive 800-volt countershock directly into the patient's myocardium while they're lying open on the operating table.
Which is horrifying. So to prevent the patient from being electrocuted by their own pacemaker, the anesthesia team has to execute strict mitigation protocols.
Very strict.
The text dictates that surgeons must avoid monopolar ES entirely if possible, or tightly restrict their use to short, intermittent bursts of under 4 seconds.
But the most fascinating protocol is the deployment of a specialized, heavy clinical magnet directly over the patient's chest.
Right. Placing that magnet over the generator completely suspends the device's anti-tachycardia therapy.
Yeah, it effectively blinds the ICD to the surgical interference, instructing the computer to ignore any chaotic high-rate signals and withhold all shock therapy.
Crucially, though, the magnet does not disable the device's backup pacing function.
Exactly. If the patient's intrinsic heart rate drops dangerously low during the anesthesia, the device will still deliver low-voltage pacing impulses to keep the biological engine idling.
And the moment the surgical closure is complete and the cautery is turned off, the magnet is removed and the shock therapy is instantaneously rearmed.
It requires a staggering amount of multidisciplinary coordination just to keep the system online.
It really does. I mean, we've explored the sheer violence of accessing the mechanical pump and how the STS database auto-calibrates the risk of failure.
Yeah.
We've mapped the ventricular volume with ultrasound geometry and debated the plumbing solutions, weighing the aggressive weed-like pathology of stents against the systemic rerouting of a bypass graft.
And we've decoded the electrical grid, observing how an intentional microscopic firebreak can terminate a lethal short circuit.
For you listening, this interplay of mechanics, fluid dynamics, and electricity is the fundamental reality of modern cardiology.
Yet, despite mastering the plumbing, mapping the electrical grid, and refining the surgical risk calculus to a fraction of a percent, the biological engine still harbors phenomena that defy simple mechanical fixes.
Like what?
Well, the text outlines a mind-bending paradox known as the wavefront phenomenon and reperfusion injury.
Okay, what is that?
When a coronary artery is completely occluded, the downstream myocardial tissue is starved of oxygen and begins to die. The standard mechanical logic dictates that the immediate definitive solution is to rush oxygenated blood back to the starving tissue as rapidly as possible.
That makes total sense.
But the clinical reality of restoring that flow is completely counterintuitive. Reintroducing oxygenated blood to severely ischemic tissue actually triggers a violent destructive cascade.
Wait, restoring the blood causes damage?
Yes. The sudden restoration of fluid and oxygen creates a massive osmotic gradient. The mitochondria, the microscopic power plants within the heart cells, have been starving.
Right.
When the blood flow is violently restored, these power plants are suddenly flooded with oxygen and massive amounts of calcium. The mitochondria hyperabsorb that calcium until it forms solid calcium phosphate crystals inside the organelle.
Inside the cell?
Yes. The sudden crystalline deposition, combined with explosive cellular swelling from the fluid shift, causes the mitochondria to physically rupture. The cells literally crystallize and burst from the inside out, leading to immediate irreversible necrosis.
So the exact biological mechanism required to save the starving tissue, the restoration of oxygenated blood, is simultaneously the mechanism that destroys it.
It is the ultimate physiological irony. Reperfusion injury proves that the heart is not just a collection of pipes and wires that can be swapped out at will.
Wow.
Mitigating that specific cellular destruction, basically figuring out how to safely reintroduce life-saving oxygen without detonating the starting mitochondria, remains one of the most complex, unconquered frontiers in modern medicine.
Because you aren't just fixing a broken pipe or snapped bone, you are tinkering with a magnificent, highly volatile biological machine.
Very true.
And sometimes the most advanced life-saving tools we possess only serve to illuminate just how incredibly complex that machine truly is. Keep exploring, keep questioning, and we'll catch you on the next deep dive.